sort of a repetition. What I wanted to say was what the previous speakers just said. I mean, if you look at HSSP 4, there's a specific session for social welfare services. But since day 1 and day 2, we didn't hear anything about social welfare. And unfortunately, even people who would have contributed to the discussion around social welfare services are even not in the house. So maybe we need another opportunity at some time. In the process of developing HSSP 5, there should be enough consultation on social welfare services.
Thank you. One of the things I learned yesterday, and it's that action has been taken by TAMISEMI to address the issue of health in all policies, because that's how we can have the multi-sectoral being implemented. So I was happy to see that one.
Thank you. That's not all. It's just each one picks one thing, and I think it was a marvelous session. So, Mr. Chair, let's move to.
Yeah, I just wanted to share with the meeting on one thing. I think yesterday, Dr. Catherine made a presentation on the HSSP 5 formulation processes. And I think it is very important to share with you on the alignment of the guiding documents. With this, I meant to say that when we were formulating the HSSP 4, our policy was a bit outdated, sort of, because the policy was formulated in 2007, and when we were formulating the HSSP 4, definitely there was some issues which emerged, and one can say there were some new issues which was already emerged in the health sector. So in a way, the HSSP 4 looked as if, one can say it was looked as a guiding document rather than a policy itself. So I think this time around, we are very fortunate because when we are preparing to formulate the HSSP 5, it is the time when we are reviewing the health sector policy, and to such that we'll be having a good opportunity to make sure all these documents are aligned accordingly. Another thing, we managed to have the 2007 policy, but we didn't formulate the health policy implementation strategy. We didn't have that. But this time, we have already completed the draft 2 of the health sector policy, and we have already formulated the health policy implementation strategy, of which we want to have a very good alignment between the health policy implementation strategy and the health sector strategic plan 5, because the health policy implementation strategy is assumed to live longer, equivalent to the policy itself, while the HSSP 5 will be assumed as a mid-term plan, sort of. We expect to implement it in 5 years' time, and definitely it will be just a part of the health policy implementation strategy. So we expect that at the end, there won't be some sort of misalignment as we had in the past. I think I felt that this was important to share with you.
Thank you very much, Mr. Chair. I think that is timely, and those were some of the questions we were receiving yesterday in some groups, especially the governance group. They raised this issue several times, and I'm glad you mentioned it. So today we have a half-day task, which might go to full day if you don't cooperate. So after this recap and overview, we are going to have a group work presentation, and then we'll break for tea while we are preparing the priorities, because we have, then after tea we'll discuss the priority themes for, priorities for HHSP 5, as well as for next policy meeting. Then we'll have a way forward from the DPP, and then vote of thanks and closing. So it's a short day, but it could be longer. So are all presentations in? Yes. Thank you very much for your group work discussions yesterday, and we now invite the group rapporteurs to make the presentation. We'll follow the order which was listed, and it's not order of importance, but all of the 7 groups are important. So group 1, please step up and present your result. Fortunately that the secretariat and the consultant prepared a template, so it will be very easy to follow all of the presentations. Asante sana. As he is preparing there, one of our colleagues left a charger for the MacBook. So if you've seen a charger of the computer, please hand it over to the secretariat or to me, and we'll get it to him.
Thank you. Can I just go ahead? Yes. Thank you. Good morning, Chairman. Good morning, everybody. My name is Redempta Mbatia, and I'm going to present the work done by Group 1 on governance on behalf of my group members. We propose the following motto for the upcoming health sector strategic plan number 5, that is, no one is left behind. Kwa maneno mengine, tutembee pamoja. So in the big picture, the vision and general key issues that we thought we should share with you all. First of all, we expect the next health sector strategic plan to embrace transparency and accountability at all levels, beginning from the community, district, regional, and at national level. And we also expect participatory and inclusivity management. We also expect that communities will be informed in a language that they also understand about the strategic plan and the strategic direction, so as to enable them to fully participate in its implementation. We all believe and know that information is power. We also expect it to allow harmonization of governing structures and resources at all levels. To cite one example, the health facility governing committees, for example, do not talk to each other with the other health committees at local government level, in the grassroots, and also at district levels. And also the resource allocation in health budgets, the percentages mentioned, for example, for the CCHP is different for those for the health facility, so we expect all these things to be aligned and harmonized. We expect beneficiary feedback mechanism to be in place. People who provide health services are accountable to those who are recipient and those who use, and therefore there has to be that system which is also structured. And we expect to have a governance maturity indicators to monitor readiness of different governing structures on their ability to manage specific health resources. We also expect gender and inclusivity of all ages, for example, adolescents, youth, and also the elderly, to be part and parcel of planning and also implementation. In step 2, the strategic directions in our thematic area, which we expect to be achieved in the next 5 years within the governance structures, we expect trickling of the sector-wide approach to the regional and district levels, and we expect revisiting selection criteria of all the governance committees and structures. For example, we know the criteria then was anyone who had finished primary 7 could be elected a member, but you want people who go there to really be empowered to represent the needs of their communities. And we know the education level has gone up, so that could be revised. The other thing is to consider retired people in the selection criteria. There are many well-educated individuals who will soon be retired, and many of them are retired, and they can serve as resource to these committees at grassroots levels. In the private-public partnership, we expect the dialogue to trickle down to lower levels. To cite some few areas, we expect meaningful engagement of the private sector, for example, in placement contracts and service agreement contracts. We expect the private sector to complement the public sector in filling the gaps, and therefore we expect joint action in planning, supportive supervision, and execution of the plan. We expect governance maturity indexes, as I said earlier, to be in place so that the capacities needed can be also provided. And we expect the regional health management team's strategic plans to emerge from the health sector strategic plan 5. We expect all health managers from the community, I'm talking about health facilities at the community levels, health facilities at community levels, to district, regional, and national level, to be capacitated with leadership and managerial skills. It doesn't mean that if someone is an MD with an MPH can automatically become a good manager and leader. They all need to be given the skills and mentorship in order to perform their duties accordingly. The same applies to RMOs and DMOs who need leadership, management, business management, and resource mobilization skills so that they can also negotiate in a very efficient manner and ensure that resources are used accordingly. And the provision of induction package to new RMOs and DMOs, we recommend that this goes back to the Ministry of Health because the experts there understand the health issues more. The RHMTs and CHMTs and facility management teams' performance monitoring criteria should also be made. There should be some way of assessing or measuring their performance by using specific key indicators. We expect harmonization and alignment of village and ward development committees with health facility governance committees, as I said earlier. There should be capacity building also at these grassroots committees. There should be feedback and social accountability at all levels. We expect the plan to digitalize health so as to improve and also address the current health challenges. We expect leadership performance management to measure accountability. And here we saw the need to revise or revisit the OPRAS. Does it really measure the performance of the managers within the health sector? And how can we improve it so that they also become accountable? We expect to have decentralized recruitment of human resource for health to regional and district authorities. While we hear that regional and district levels can hire, but the environment or the guidance from the policy area has not yet allowed that. So this is what we expect should happen. The SWOP Technical Working Group formation, we recommend them to be aligned to the health systems approach, the 6 WHO building blocks, instead of having them disease-based, because with time we have new diseases all the time. We expect that the plan will ensure community health systems are reflected vividly under the SWOP. And we expect that the regional referral hospitals will be linked to training institutions to leverage resources and in capacity building. For example, zonal health centers can be linked to the regional referral health hospitals, whereby experts or specialists from the hospitals can be used as resource to train health providers at the zonal health centers. Likewise, the zonal health centers experts do not always train, so they can always also be used to provide health services at the regional referral hospitals when they do not have trainings in place. And finally, the strategic direction, we expect to integrate disease prevention policy from primary, secondary, and tertiary levels within all levels of the health system, from the district to national system. In step 3, what are our strategic directions to be implemented during the first year? We recommend the following. First, to have review of the governance structure from the community to national level, as I said earlier, to address holistically the gaps that we have listed in step 1. And we expect community level engagement in planning and social accountability. This is something that can begin immediately. We also expect meaningful engagement of the private sector in service agreement, diagnostic, imaging, radiology, and infrastructure. We expect health managers will be equipped at all levels with leadership and management skills, including measuring their performance. And finally, we expect to strengthen SWOP and review it and revive so that it can be a strategy that we continue using. Our concluding remarks: governance under the health sector strategic plan number 5 should be inclusive with a focus on accountability, transparency, participation, responsive and people-centered from community to the national level. Thank you very much, and these were the group members under the leadership of the Director of Curative Services. So if there are any things that I missed, I welcome my group members to feed in. Thank you.
Thank you very much, Redemptor, for that well presentation, and thank you, Group 1. That was very nice. And one day I met somebody very senior who I knew before. So when I started, I introduced myself. Oh, you know, I'm Mkutano. I started working there. Then when I wanted to say what I wanted to say, somebody called him away. I lost the opportunity. So I don't want you to lose this opportunity. I just want you to say what you want to say. No stories. No, before it was like this and whatever. So when I give you a chance, just say, add this in the strategic direction, add this. No stories. Sawa jamani? Okay. 3 people. Yes. Yes. Another one?
Asante, Dr. Ipuge. Mine is a very quick one because I was part of the group, so I'd like to add. I'm Dr. Ellen from Kappa Foundation. We also discussed about strengthening the multi-sectoral collaboration and coordination in the group, that we would like to see other sectors coming on board in the swap. That includes the Ministry of Finance, more active participation of PRLG and other sectors that have influence on the health. The second thing we also proposed is the stronger swap approach and coordination or collaboration between the ministry and PRLG, jointly meeting the NSAs as well. Similarly, the way they do by meeting the development partners, they should also be meeting the NSAs in one joint meeting. So that was the second. The third one was on the retired. I think she mentioned about retired people being in the Health Facility Governing Committee, but maybe we could say having a good mix of young and the retired as well, not forgetting the young population as well. Thank you.
Thank you. I think she mentioned 3 for 3 people, so let's clap for this group. Very good job. I call upon Alex. That's it. I know Alex.
Mr. Chairperson and dear members of the floor, good morning all. Yes, I'll be presenting for Group 2, which was working on health financing. Yeah. Our motto was proposed that we should have, we'll have health financing, which has health financing system which reflects the middle income status. Then our big picture, it is on UHC, universal health coverage, especially on financial protection, ensuring that there's cost-effective quality health services for all without financial barrier at the time of need. By the way, we found that the previous national health financing strategy is still relevant to until within the range of time for HSSP 5. So you'll find that most of the contents will still be reflecting the previous health financing strategy. So our strategic direction, based on our vision that we are expecting that our country will be reaching the middle income status, that now we are expecting the domestic funding to increase, that is both government and private, and we expect to explore innovative ways of raising the money to finance the health sector, such as sin tax and other progressive means which ensure that those who are rich are subsidizing the poor. Also, the issue of advocacy to ensure that the government is increasing spending in the health sector. Without forgetting the poor, we thought that this strategic plan should explore on how TASAF mechanism, that is, how the poor could be financed, taking into account that poverty is also one of the, health is one of the clusters of poverty. So how we can link the TASAF system and the identification of indigents, that we can see how they can be supported also to access quality health services without financial barrier. Another area, it was improving efficient use of available resources. So a wide range of ways could be checked or will be focused on, such as adopting improved provider payment mechanism, harmonization of funding flows, such as we know now that we are using DFF to the facilities specifically for the money from the basket fund, but we have other sources of money also, finance, which the facilities are receiving. So the new strategy should think on how this money could be channeled through DFF too. Another thing, it was the alignment of public financial management and the health financing to ensure that, such as in ensuring there is timely disbursement and the use of funds accordingly. Also, to remember on improving efficiency, the studies which have been conducted, such as NHA, we found that there is no such resource gap in implementing HSSP4, but the problem could be on how this money were allocated. Maybe they were not allocated to the areas which could have no, did not target the social objective of financing. The other thing, it was we'll focus on expanding the share of prepayment modalities, such as taxi and insurance in sectoral financing. Specifically on establishing the single national health insurance. Under this, we also thought on people contributing to the health insurance through economic activities. So we thought on flexibility, because people are in different sectors and with different characteristics. So the modality of payment could also be checked to ensure that every person has a chance based on his or her activities. Then we thought on having community strategy as well as individual household to ensure that we have higher coverage, more people are covered, in order to do away with the catastrophic expenditure and ensuring that no one is left behind. The other thing, it was improving understanding of cost of services for improved allocation of funding. Then integration and the regulation of private sector and the regulation of prices for health services. As we know that we don't have a clear guidance on the prices set for health services. So we thought on this HSSP 5 that should also come with that aspect to ensure that we regulate the price for healthy services. Another issue was exploring the opportunities for corporate social responsibility. But this should take caution on the aspect of governance, because the private sector would like to see where this money is spent. So the issue of transparency, if this is to happen, we need to ensure that there is a good reporting system that people could see where their money were used. Another thing, it was to improve resource mapping and tracking in order to generate and use the data for decision making. This is, as previously we have been conducting the PER and NHA, but we would like also to have tracking on the part of budget to see the gap and to address it, and see the way on how we can address it. Then we came to the strategic priorities for HSSP 5, which is to increase coverage under CHF and NHF for the current, from the current level. This will be a short-term plan when we are still waiting for the single national health insurance. Then to increase the efficiency through improved payment mechanism within ICHF and NHF, also and other sources of finance. Then it was to strengthen prospective resource and retrospective resource tracking to better align partner funding. As I said earlier, that we should, this would give us a good way on how we can use the fund to the areas which calls attention, also focusing on social objective of funding. The other thing, it was the process auditing of the H-basket fund to identify and resolve delays in disbursement of fund. Then conclusion and remarks that we should complete the national health policy in order to provide the basis to HSSP 5, because it is one of the framework which should be reflected when we are preparing HSSP 5. The other thing, it was the full involvement and participation of all stakeholders who will be who should be involved in the preparation of the guideline of the strategy itself. Then to ensure there is a linkage between the components. This is at we have as now we have a number of groups which have of which we are dealing with different themes, but we should make sure that there is a good alignment and the complementarity. For example, between financing and the services provided. So we should not act. These components should not go independently, but we should see the linkage on how they support each other. The other thing, it is presenting initial output of this exercise to the TWG, because the technical working groups needs a chance also to discuss on and add more inputs on where they think there are gaps. Another thing, it was include the development of 5 medium-term strategic plans for each implementer in the roadmap for HSSP 5 formulation. And the last one, it was include effective dissemination of HSP 5, that once it is completed, in order to ensure that all the actors in the sector understands it. Thank you. And I would call or invite our members, if there's anything forgotten, that they can add up.
Thank you, Alex. Thank you, Group 2. That was a wonderful work done and good presentation. Any feedback from the same group or any other? Yes, please. Mike, over there, 2 people. Financing is a big issue. Governance, go for governance. Finance. Any other?
Yes, good morning. My name is Peter Masika, the CEO of Tanzania Youth Alliance Tayo. I was a member of the group, and I was the one that proposed the idea of looking for health coverage for the poor through TASAP. The idea I would like to elaborate a bit is recently it was in the newspaper. I think they got Tanzania government got a loan of, I think it's 1.2 trillion shillings that will be managed for TASAF, by TASAF for the poor people. We thought one of the big, that money, part of it is going to be used to support the health by the family themselves. We thought if it was possible for TASAF to work together with the NHIF so that they can have a special package in such a way that they can negotiate with the World Bank so that part of that money, maybe 1 month payment installment, can just go directly into that portfolio so that they can have a coverage. And through that, it means that it will become something that already they are covered and it will help a lot.
Okay, so that's already included, okay? So,
It's just about further clarification on health financing. It's about regulatory body. We talked about regulation of private sector as well. But my consideration is it includes not only the private, also the public service, because all can be affected in one way or another when it comes to health financing issues. So it's just a clarification on that point of regulations, regulatory body.
Yeah, just a minor point. At the beginning of the presentation, I was part of this group. It is labeled as planning, and actually this is health financing. Just a minor correction for the Secretariat.
Financing, not. Any other comment? We are comfortable? Oh, sorry.
Yeah, thank you very much, Chair and the moderator. I'm not quite sure, but I was expecting also to see how we address the waiver and the exemptions. I understand the previous presentation. I noted one of the recommendations to stop waiver and exemption. But on the other hand, I think we have not been able within our healthcare services to cost the waivers. We don't put the costs of how much we have either waived or exempted. So I don't know, I just wanted to throw this for people to think further. Thank you.
Okay, I think they will answer, but I think their premise was that we are going to mandatory universal insurance, then all the services should be paid. Because when you waive, it means the provider is providing free and who pays for it. I think the group, can you answer that question quickly? Waivers, why are they not there? Who's the chair? Lusajo. Okay, please answer. Mike over there. Mike, somebody to help me with the mics, please. Secretariat, you tupo.
Thank you, moderator and the participant. For the issue of the waiver, since we are going to move for the mandatory health insurance, I think the issue of waiver and exemption will not be there. But some of the hospital, they are trying to cost on the amount of resource which have been allocated for the waiver. So in short run, we can do a start, but some of the health facility, they do their costing. But in long run, that's why we are moving to the single necessary insurance. That will be the permanent solution to ensure all people can access health service without any financial barrier, and also to increase the financial to the sector. Thank you.
So before the universal happens, because we are now, what will happen? We just grope in the dark until what happens in between?
Maybe I can ask you, one of the group members to chip in.
Thank you. I think on the side of waiver, I think the important thing to understand first is the policy itself was targeting the people who are not able to pay. The way it was interpreted and implemented, it wasn't the right way. It is the exemption and waiver for those who cannot afford to pay. And among the strategies that we put in place is appropriate strategy to cover the poor. So in a way, in a mechanism to address how to improve access for the poor, that's how we're going to address the aspect of waivers. But moving forward, there's not going to be like an umbrella waiver for everybody.
We know about going forward, but the question asked here is between now and then. So what is happening? Do we continue like this or what? Cindy?
For now, I think it's going to be like a status quo. What is happening, there's a lot of indirect initiatives that are in place. One of the major challenges that we are facing is there was no money that was flowing to the facilities to cover the services for the poor. But through the direct facility financing, that is public money, and the public money is usually meant to cover the poor. So the expectation is, for now, we're going to see like availability of more medical supplies at the service provider level. So those who are entitled for waivers have more guarantee to access services now than it used to be before.
When big nut to crack, you give one with the biggest teeth. And here is the permanent secretary. Can you help us, madam?
Yeah. Thank you, moderator. And I would like to thank Mr. Rusajo for the response he has provided to the question. Regarding the follow-up question which you have put forward, that is before the mandatory health insurance to come into operation, as a ministry we have decided to make or to argue a case before the Minister of Finance so that they can allocate us with some funds within our annual budgets and such that those funds will be allocated and paid to the facilities or health facilities which will be providing health services to those who can't pay. So it will be like a compensation funds to make those health facilities not dishing out the services freely without being paid.
I think that satisfies everybody, including me, because and Dr. Upunda, me and him are only socialists remaining.
Yes, I remained a socialist. Mwenyekiti, wasiwasi wangu ni kitu kimoja, na sina wasiwasi na mpango huu tuliambiwa wa pesa and so on. Wasiwasi wangu ni kitu kimoja. Tuna watumishi 50%. Juzi mliniambia services ziwe na human face. Nikadoubt juu ya ethics. Lakini baadaye nikafikiri nikasema well, nia ni kwa kila mtu awe na kadi ili aweze kufikia services zetu, kufikia services zetu. Maana yake ni kwamba kwa maoni yangu tutakuwa na influx ya clients kwenye units zetu. Caution yangu neta kuomba ni kitu kimoja tu. Kama sekta tujitayarishe kwa hili ambalo linakuja, ambalo serikali imeshatamka kwamba kila mwananchi tunataka tumpe kadi ya kwenda huko kwenye vituo vyetu. Kwa sababu sasa hivi vituo vyetu vinapata influx na pressure tayari na kadi ambazo zipo. Zitakapokuwa nyingi tutakuwa na pressure kubwa zaidi. Kwa hiyo ningeomba tu kwamba tujitayarishe mapema sana wakati huu ambapo tunafanya hii mipango strategic plan, tujitayarishe vizuri. Asante mwenyekiti.
Thank you very much for those who are here still learning Kiswahili, and you should fasten because next year it will be all Kiswahili. Dr. Upunda gave a cautionary note that we have discussed in this meeting about shortage of human resources for health, that we are less than 50% are in place, and also we talked about human-first services that are ethical and whatever. But we are talking about all to get access to services through insurance. If all are insured, then we have an influx of more patients to the facilities, which are already have pressure with a few insurance clients, with a few cards which are there, 7%, but the pressure is already high because you could see most of the income is coming from there. So the sector to be ready for the universal health access when everybody has insurance card. So it was a cautionary tale from a grandpa. So thank you very much, health financing. Health financing is always at the heart because we might want to do things. If there are not enough finances, we can't do. Let's move on now to group 3. Rapporteur group 3, please come to the stage and present your findings. Human resources for health.
Yes. Good morning, ladies and gentlemen. My name is Martin Mapunda. On behalf of my colleague, Group 3, I'll be quickly presenting to you the human resource for health key issues in areas of planning, management, and development. Starting with our rule or motto, we are saying we want to expand partnership base for the accelerating attainment of universal health coverage targets. Moving to big picture, in order to realize the visions and general key issues, we are saying that these key issues should be taken into consideration. The issue number 1 is addressing the absorption needs, variety of solutions, be it locally or sustainable and feasible. We are also saying that training system quality, training program design, trainee selection, training delivery competence, and the CPDs are critical for assured workforce competencies. But also we are saying addressing the inequality HLH distributions, because we have seen that there is a big disparity. The shortage of HRH is more pronounced in rural areas than urban. So between and within the councils that require system and formalized mechanism for distributions and also redistribution of health workforce. But also we are saying it's high time now we revive the deteriorating professionalism and ethical contact, but also salaries alone not enough to assure the health workforce retentions unless the system adequately supports the existing workforce. So those are the key issues that should be taken into considerations. Step number 2, we were supposed to develop the strategic directions in health workforce theme. We are saying that we have so many strategic directions that we have seen, but you will advise us whether to condense or expand more. The strategic direction number 1 is that the existing health workforce policy, we have seen that there is a dilemma of mismatch between need, supply, and demand. So this should go hand in hand with improvement in information system, as well as promotion of HRH data used for decision making. Number 2 is to do with the absorption of the healthcare workers to reduce the HRH shortage that we have seen. So this is strategic number 2, but also production of healthcare workers has to respond to current and future population needs. We have seen the existing and emerging diseases like dengue, etc. So we don't have enough health workforce for vector control, etc. So this is also very important to take into considerations. We have also seen that the quality assurance of training system, this is to ensure the workforce we are producing are of acceptable quality and that they have core competencies required to achieve the universal health coverage. This is very pertinent. But also to ensure quality is managed, effectiveness of accreditation system, and functionality of professional bodies are important ingredients as well. Quality of training should also address education systems in a holistic manner, right from curriculum design, selection of trainees, skill development, and examination systems. It should also focus policy, people, infrastructure, process, and materials. Because we have seen that we are opening training programs, but we are not considering building hospitals for teaching, for practical, etc. So there is so many congestions of interns in our hospitals. But also other strategic direction is we are saying we need to have appropriate mechanism for staff appraisal. This is to do with OPRAs and other mechanism of evaluating the health workforce productivity. But also strategy to improve execution capacity. Group number 1 said it already. We need to capacitate our managers so that they can be able to manage and the health services. So step number 3, we were supposed to come up with things that we think we are going to implement for next year and onward. First thing, we are proposing to fast-track approval of COSESCA model. This is for fellowship or attachment of medical specialties. We're also proposing formalizing and support alternative hiring arrangements, recalculating the staffing needs to address mismatch between needs, supply and demand. We have seen that the current traditional method that we are using to determine our human resource for health requirements by using maybe number of beds, burden of disease, or technology is not enough. So we need to come up with innovative ways, and we were suggesting to use the workload indicators of staffing needs. But also curriculum update, including improvement of training quality assurance mechanisms, starting process on production of cadres with acute shortage, including cadre that will respond to emerging and re-emerging disease. As I have said earlier, that we are, there are some cadres which are rare and some cadres which are not enough. For instance, the vector control cadre, orthotists, dentists, but also physiotherapists and the other cadres. These are very acute in numbers, but also they are very rare. So those are proposals that we think for 2020 and 21 should be taken into considerations. So by concluding, this is our advice. We are saying, taking the product of this meeting to further develop draft 0 of the parts related to the thematic area. But we are also saying it is very important to share the draft with the HSSP5 core team and the HHSP5 consultant for comments and wider sharing with other stakeholders. We also advise that we need to update and share with the wide stakeholders, but also the product of this meeting should be incorporated into the HRH coming strategic plan and the other HRH guidelines aligned with the strategy. But also, we advise to have the resource mobilizations and advocacy on these key HRH issues. This is the end of my presentation. I'm happy now to call upon my colleague, maybe for top up. Thank you.
Thank you. Thank you very much. Thank you for that presentation, the presenter as well as the group. Human resource is important, we all agree. So if they covered, is something else so you want to add, group members or others? Your hands, please. Yes. Jamani Secretary, yeah, please help me with those.
Okay, thank you. My name is Victor Bake. I'm from UNFPA. So I was a member of this HRH group, and I want to suggest something that we come out from the discussion, which unfortunately I have not been able to see it. And this is upon the HRHMS, the Human Resource Management Information System. So we thought this is a very important system that has been available, but when you go to the system, it does not provide the real-time data information about human resource for health. So we were advocating that we have to find a mechanism to make sure this system is functional and able to provide the information which will be valid for planning and also advocate for more human resource for health. Thank you.
My sister.
Thank you so much, HRH group. I've got like 3 points. One is I saw there was a priority on fast tracking for SESCA and Hexacon, but in the final key 4 points, I think it was only COSESCA, so I was not very sure if it is just a typing error or something, I don't know. Because the two represent different cadres professionals, so I'm not very sure if you want to fast track both or just one, the COSESCA and then not the hexagon. So that is one. But I still didn't see much of the motivation strategy for human resource. I understand in the first or second slide, it was broadly stated, but I think there's some experience we had in the past. Some local government authorities, they were motivated and they are doing a lot of, support to staff who report, especially those in peripherals. So I'm not very sure if you don't want to use such kind of experiences to ensure that healthcare workers are motivated to be able to undertake their tasks. Because there's a lot of examples, here in Tanzania. But the other issue is also on absorption. There was a time, I remember, I think I was in Newala or something, and I learned the local government was, that time, graduates might stay 1 year without being absorbed by the government system, but the LGA were able to do short-term contract with them. It wasn't a salary per se, but it was something like a stipend for a period of sometimes 1 year before they are absorbed, which I think it also motivates people to work, but also to learn, because when you stay at home, you can't learn or do anything. But my last final thing, in the midterm review, we have seen the critical issues which we have, mortality, particularly newborn and maternal, and also increasing of NCD. But I'm still feeling that in terms of mortality, particularly for maternal and the newborn, we are not coming up clearly with the strategies which we know they work, especially, for example, ensuring that we invest more on midwifery workforce. It's not coming out clearly, so I'm not very sure if at which stage we're going to talk about it, because we have a lot of challenge in terms of competences, in terms of skills, but we're not talking clearly. So I'm probably at another stage, but I'm worried that since if I can refer to the midterm review, but also to the WHO presentation, that all the regions, Africa region, including Tanzania, mortality is still high. And they also say the same thing which the midterm has said. But what critical thing do you want to do and change in the past 5 years, the coming 5 years, and of course, in 1 year? What do you want to do? Thank you.
You see, I couldn't stop her. My sister from Skumaland, they are very tough. I wouldn't dare. But her points are spot on.
Thank you very much. I would like to remind one thing about the country. The information communication technology is growing very fast, and as we can witness our country, the supply of electricity all over, even the rural areas. So the issue of telemedicine, I would like to feature in the health sector strategic 5, because even the people in the rural areas can enjoy the super specialized services from the center of the regions or from the center of our country. So I think even the career development, recently we were doing video conference right from the TAMISEMI to the regions. So likewise, we can enjoy the technology even in health sector.
Thank you very much, Rosina. Then you.
Thank you very much. I think we needed to look at the training institutions. Are they training the material or the syllabus that responds to our needs? We should probably conduct research. What are the human resource students, training? What is taught to the students, and see if it really responds to our needs in the service delivery. Thank you.
A quick clarification on EXA and
EXA, Mwenyekiti, is the institution. EXACON is the first college that was established by EXA. Sasa walipoona faida ya Hexacon, wakaanza other fields in the same program. Wakaanza surgery, wana program ya fellowship. Walikuwa nilipowaacha mara ya mwisho walikuwa wanafikiria kuanza program ya pediatrics. Walikuwa wanaanza vile vile kufikiria program ya physicians and so on and so on. So EXA is the institution and the colleges are under the institution ya EXA.
So in short, it's the EXA model, not the Hexacon or EXA COSEXA or whatever. It's the various. So it will be rectified. Yeah.
Thank you, Mr. Chairman. Thank you, Madam Chair, and thank you, Coordinator. Congrats to the group on the work done so far. I have 2 comments or 3. We talked of a succession plan. I have not heard about anything on succession plan. We are growing, we are getting old. So we have to have a phasing kind of thing in training programs. 2, training of middle cadre and low cadre staff. Not everything can be handled by a specialist, never. You need some technicians down the road. 3, not heard of capacitating human resource levels, all human resource levels on operational research. We were warned not to go to the operational level, but I think some kind of research is useful to get some evidence on the road. I also want to repeat on the motivational strategy. Please, the retention of staff needs some kind of motivation. Thank you so much.
Thank you, Dr. Ipuge, once again. Mine is very few points, 2 points. When we had a presentation from one of the consultants, I think he mentioned very clearly we should try and see what are the local solutions that have worked best in the country and how are we able to scale them up. And I think we're all aware of the almost 10 years solution which has been innovated by Mkapa Foundation, Mkapa Fellows Program. And it has worked very well, and it has been rolled out in a number of projects that have been initiated by the government, by the Ministry of Health and PRL in collaboration with Mkapa Foundation, to make sure that we have available, qualified, skilled health workers in place. So I think this is something we need to think through again. Why don't we just scale up the same model? I'm just building upon what my colleague from UNFPA mentioned. Same way, placing skilled workers for a certain contractual period, and gradually when the government is releasing this permit, they're being absorbed. And we've been doing it very successfully in collaboration with PRL and Ministry of Health. That's one. The second thing, I know sometimes the CHW appears under the Community Health Promotion Technical Working Group. But I think when you look at the CHW concept, it's about HRH. So is it timely now we shift that CHW issues coming back to this technical working group? And while we utilize the Health Promotion Technical Working Group just to see the systems and the structures of how we strengthen the community-based health program. I think this is something we're missing. One last point, sorry. I didn't hear much on the e-learning. If we are moving towards technology and the e-learning program, can we think about it too as well? Thank you.
Thank you. A few years back, it was fashionable to talk about task sharing and task shifting. A lot was talked, a lot was written, a lot was argued upon. I wonder what happened to it, because it was all within the context of human resource shortages. So does anybody talk about this? Is it still relevant? I just want to know from the present cadres what they think about this. At one time, a very fashionable word.
Okay, heated discussion. Can the group do a quick response with the group chair, with Hadija?
Good morning. The comments that are coming still provides an evidence that HRH is still an issue. And maybe, I think it's, moderator, nilitaka kukuomba nijazie kabla hata watu hawajauliza maswali. We've covered most of the things that you are saying, but the issue is we were told to put it as a strategic direction. And there are few things that we have not considered, which I agree. The issue of midwifery, we've said we will focus the competencies that are needed. So competencies that are needed, when people go to make it operational, they will decide which kind of competencies we should be looking at. So we've tried to portray at a very strategic level. And another thing that we've also included, Dr. Helen, the Mkapa Foundation is mentioned in our strategic direction number 2, where we said revisiting the achievement of previous strategies such as Mkapa Fellows experience and many others that will enhance absorption of staff. So it is in the strategic direction. And another thing that we did not, which we did not consider, and thank you, Dr. Berege, is the whole issue of succession plan, which will put in training as well as on the HRH management. But issues of motivation, whatever, it will go in the strategic direction number 6 on appropriate mechanism of staff appraisal, internal supervision, and effective job allocation are important. But there's something that we said, salary is not enough. You need to have a supportive system to make the HRH work. So all these things will come when we go down now to the nitty-gritties of each area. Thank you.
Thank you very much, Adija. HRH is another area where a lot of issues come about. So we'll move on to the next group. And as we are moving on, there is a lot of talk about IT and transaction. So RMO, DMO, look at your phones. If you have received a transaction, keep quiet. If you have not received any transaction you can see the secretariat. You know what I mean. So. So we'll see who is dominant. Is it ICT or MNE? The marriage which was convenient.
Madam Chair and good morning. I'm here to present the strategic direction as we have discussed yesterday in a group work number 4 for ICT and MNE. So we have agreed to, as our motto for the coming HSSP 5, as a better data at fingertips. That means to ensure that everyone or every decision makers and even the people who are actually working at health facilities have the access to information for them to be able to make appropriate decisions at their fingertips. So the development of the technology should help the people to get information timely and be able to make decisions appropriately based on the facts that they have at their fingertips. So our bigger picture that we have seen as the vision and general key issues that we have seen as very important for the development of the digital health systems is to have integrated data systems that are comprehensive but also interoperable, having reliable and accessible systems so that at every levels of the decisions, at every levels of it's like facility level, and the higher levels of decision makers should have access to these informations and be able to make decisions based on the facts that they have. So all these issues should impact or improve the health outcome as our target. So what are the strategic direction now that we have put in place? We have seen a number of issues that need to be addressed so that to be able to achieve our visions that we have just mentioned earlier. One of them is to improve the digital governance structures. It's like as we are moving towards the development of these initiatives, we should have a strong governance structure to oversee the implementation of all the initiatives that we want to implement, so that to be able to make sure that the objectives of those projects that are in place is achieved as expected. So that is one of the areas that needs to be addressed. And on top of that, we need to have like what we call a Center for Digital Health. It's like a think tank for the digital health solutions, of which we may have an expertise who will be responsible for making sure that all the digital investments that we are having is adherence to the standards and guidelines of which we put in place. So that is one of the areas that we think it's very important for the success of the digital health investment. But the other idea is to have a systems or information system which helps the decision makers to make appropriate decisions based on the information that they get from those information systems. And the other one is we think it is possible to emphasize the use of these information that we are collecting from the point of generations, like at facility levels, the one who actually are entering those information that we actually use for the statistics, like in DHIS2 and other platforms, to be used at the point of generation for them to make appropriate decisions and sometimes make interventions based on the facts that they have at the systems. So the other issue is the unique client identifications. So this is also came up as one of the most important thing that needs to be addressed as well. And the good thing is the Ministry of Health is, and in collaboration with the TAMISEMI is working on that project as well, to make sure that all clients which are getting the services from different facilities have the unique identification, so that to be able to get appropriate statistics on the services that they receive from different point of services. So it's one of the areas that needs to be addressed in the coming HSPP 5 as well. But also there was a concern of having too many systems which are not integrated, which are not interoperable to each other. So it seems like it's very difficult for the health facility workers, to work on the primary assignments, and then working on the systems which needs to be fill the different informations. It's like the same information into different platforms. So there is a need of having interoperability between these systems, and not only the interoperability, but having the integrated systems, and to reduce the number of systems of which having the, it's like serve the same purpose as very difficult for the health workers to work on that. So it's one of the areas that need to be addressed as well. And the good thing is the President Office and the Ministry of Health also have already started to work on that. And there is what we call the Health Information Mediator for the case of the Ministry of Health, which tries to integrate those systems which are used at facility levels. So that is the area that need to be addressed as well, and the project, the work is still on progress. So the next strategic direction that is important is to improve the human workforce through innovations. It's like we need to have people who will be able to help us to develop those systems and initiatives, and not only to develop but also to make, it's like to support the people who are using those systems and make it sustainable for the current and the future generation. So we need to have a human workforce at the facility levels, but also at the ministry level and others like regional and the district level. We need to have those people who will be working closely to make sure that these projects that we are deploying to facilities are actually used as and appropriate, and are used, and we are getting the information that we want as expected. But also there is a case of having data reliability at all levels. To have data is one thing, but also that data to be reliable for the decision makers to make decisions. Because sometimes you may find you have data, but everyone is questioning about the quality of that information that you are providing. So data to be collected through these information systems should be reliable, timely, accurate, and quality is a key, and to be able to have like a comprehensive and it's comprehensive systems which can be able to provide those quality informations and be able to be translated easily by the decision makers. So that is the area that also need to be addressed as well. But also there is a case of data privacy, confidentiality, and security. And when we talk about the health data, we know the importance of confidentiality and the privacy. So it's one of the things that need to be strengthened, so that to be able to ensure the privacy, confidentiality, and security of the information that we are collecting from the facilities. But also there is an area of improving the accessibility of healthcare services through technology. It's one of the member today mentioning about telemedicine. So when we are talking about equal access of the healthcare services, it's like whether you are in rural or urban area, as long as the technology can link you with the experts who are actually most of the time based in urban areas. So through telemedicine, you can get the services whether you are in rural or in urban area. So it's an area that needs to be actually addressed as well. And the good thing that we have already started to work on telemedicine projects as well. So we need to strengthen this area to be able to allow people from different places to have access to the resources that we have. We know the number of health workers that we are having, especially the specialists, are not quite big enough to save all the community. So it is a high time for us now to use the technology and the capability of this technology to be able to provide access to those people who cannot be able to access those specialists or services that provided in some of the facilities. The next strategic direction that we're seen as the important thing is to have a reliable ICT infrastructure, including reliable network and power reliability. Because without having the infrastructure in place, without having connectivity in place, without having reliable power connectivity, reliable power supply, you will not be able to get those information. And even the digital system that you will put in place may not work properly due to those factors. So it's the area now that need to be addressed as well, considering the number of health facilities we have in the countries. It's very huge. But also we have discussed about the capacity building of health workers using the digital technology. It's very important as well, because we need to capacitate the people who are working at facilities, but also the technical guys who are actually developing those systems, supporting, maintaining it. So it's very important for them to have a proper knowledge on how to run or to operate those systems as well. But also there is an area of digitalization of healthcare services. So here there is a lot of discussion, but we have put aside the number of digital health systems that need to be prioritized in the coming 5 years. So that to have like a guiding and the strategic directions toward the implementation of these digital health systems. So it's an area of which needs to be also addressed as well. But there was an issue of having a lot of indicators within our digital platforms, that we are collecting a lot of information. Sometimes some of them are not even used by the user. So it's an area now we need to look at having reviewing the indicators and the data elements that we are collecting from the health facilities, which are actually add value to the user of these systems. And also we have an area of thinking about having introducing artificial intelligence technology to these initiatives that we have, so that to be able to strengthen the digital systems. So it's a thing that needs a lot of discussion, and this is not just a thing that we may think maybe tomorrow we can do it, but having the basic digital systems for data collections, the basic functionalities in place, and then we will think about having the artificial intelligence technique to improve the quality of the information that we are collecting from these facilities as well. So we have put aside the strategic priorities that need to be implemented in 2020-2021, and out of those strategic areas that I have just mentioned, we have seen that few systems that are integrated and linked to DJS and other platforms is one of the strategic direction that need to be addressed in 2020 and 2021. And this is very important because we have too many fragmented systems which are actually collecting information at facility levels. It's like we have program-specific systems. It's like if there is, for instance, if there is a problem in malaria program, we develop systems for just saves the purpose of malaria. And then if we have a problem of collecting information, for instance, regarding the HIV, OTB, we normally concentrate on having the system for those specific programs. So that is the area that need to be addressed. And our direction is to have a comprehensive system that saves the purpose or the requirements of each program that we are having. But this system should be well integrated. So there will be no duplication of information being available at specific programs, but not linked to other programs as well. Because we are saving the same patients, whether someone who is suffering from malaria may go to to seek for the service for malaria, but also the same person may have the HIV problem, the same person may have TB. So all these information systems that we are having should also, in one way or another, being integrated together so that to reduce the number of duplications and multiplication of efforts and reducing the burden to health workers being busy filling those information that we actually need for decision making. So the other area is the interoperability, which is information exchange, and then to emphasize on the use of data for making decisions, but also data use at point of generation, data reliability, it's important, but also improve digital governance structures like the one I have just mentioned, and also the unique identification to improve the, to reduce the duplications of clients, and also data privacy, confidentiality, and security is the key, and it's very important to be addressed as well. And improving equity, it's like accessibility of healthcare services through telemedicine. It's also the area that need to be implemented in 2021. And finally, to improve the human workforce through innovations. So to finalize the presentation, we have a number of concerns that we have discussed yesterday, and it seems like it's very important to be addressed as well. One of the concerns is we have seen the priorities, but we have the system in place right now. And the important thing is to strengthen what we have, not to start a new thing. But that is the area that need to be addressed as well. The other one is to use existing data and analytics. And the priorities should reference available strategies. We have digital health strategy for 2019 and to 2024. And also the monitoring and evaluation for 2019-2024. And also we have health information system guidelines for 2019. So all these documents should be used as the reference for prioritizing the strategic directions for HSP 5. And also to have the key performance indicators for each priority that we put in place. And the document to differentiate system functions and service delivery is also the key. And also to embrace the local innovations and expertise. So it's very important to have the people within the country who will be working on these systems, so that to be able to make sure that the sustainability of those systems is assured as well. And also to use experts from the universities, like what we have seen from the DHS2 perspectives. The University of Dar es Salaam is the one who is leading the process. So we encourage the use of the expertise from within the country to be able to, operationalize and implement these strategies. And lastly is to align curricula to meet actual demand through multi-sectoral collaboration. Asante.
Can you go to the last but one slide? Can you go to the last but one? Yeah. So thank you for the presentation, but I want to say at the outset, before tea break or during tea break, the group to reconvene and give me 4 from that list. Okay. So, but otherwise, thank you very much. You have captured all, but I've not heard some words. Grace, you want to start with the comments?
Yeah, good morning. I just want to compliment, I was from that group as well. Yeah, especially